It's been an interesting journey here this morning. I went through that sort of thing of being in central London at 4:45 in the morning, and there's absolutely nobody around. That was amazing. And then that moment on the plane when you've got your cup of coffee in your hand and turbulence strikes, and you're sitting there going, what do I do with this? Realising that you have a white shirt on. And then that spectre of the idea that I'm standing here with a huge brown stain down my front, that passed off without incident. And then I got a taxi from the airport, and we'd been in the taxi about 40 minutes, and we were sitting going nowhere. And the driver said, "So do you have an umbrella?" I said, "Yeah." He said, "You can get out and walk, it'll be much quicker." So I did so and had an interesting walk through your roadworks, and found my way here. Actually, it reminded me of the last time I was here and going back to the airport, and I got in the taxi, and I said to the driver, "So how long would it take to get to the airport at this time of day?" And he said, "Well, if there were no traffic, it would take about 20 minutes. But then, at this time of day, there's never no traffic." Which I thought was the most helpful thing I'd probably ever heard. I've gone all sort of high-tech, and I now do my preparation on my Kindle. The only problem with that is you get sort of these spam emails come in, and I just had one asking if I wanted to make a funeral plan, which I don't think I do right now, although, yeah, never mind. So I know that when making a presentation, many people suggest that the most important message in the presentation, if you like, the punchline, should come at the end. Well, I'm going to face down convention, and after a bit of context setting, deliver my punchline early. So I was in Geneva a couple of years ago at the World Health Assembly, and I attended a side event on public-private partnerships. And much of what was being said was interesting, but I had a nagging feeling that something important was being missed. And then it occurred to me what was nagging at me. People were talking about partnership as though it was a simple formulaic response to complex issues. But they come to that time at the end where you can ask questions, make comments, and I couldn't resist the opportunity to contribute my overrated wisdom to the debate that ensued. And after a few preliminaries, explaining my experience and field of work, very pompously announced that partnership is a mindset, not a formula. So imagine my surprise when I found this pearl of wisdom being tweeted as though this was some kind of new magical learning. So there you have it. Partnership is a mindset, it's not a formula. And furthermore, in my world, it's about relationships and not about systems. So let me give you a little bit of further context and explain what it is that the organisation I work for does. So over the past 25 years, in fact now 27 years I think, FTHETS has been working to develop a credible model of partnership to help train, educate and upskill the health workforce in developing countries. Over the years, around 200 health partnerships have emerged, partnerships between UK health institutions and their low and middle income country counterparts, using professionals from the UK health sector to deliver capacity development initiatives to their counterparts in those low and middle income country settings. So 5 years ago, the UK government, through the Department for International Development, which is our equivalent of Irish Aid, funded a £30 million programme called the Health Partnership Scheme, which THET manages on their behalf. So what was the motivation for this unprecedented level of investment in an unproven methodology? Well, they wanted to see whether this kind of institutional partnership model could maybe deliver results in capacity development of the health workforce, which more traditional methodologies found difficult, particularly around sustainable behaviour change. So within the programme, which we shortened to HPS, so far over 50,000 health workers have been trained. and they've been supported by over 1,700 unpaid volunteers from the UK health sector, with the ultimate measurable outcome of improving health services in the target areas. Now, traditionally, if a training need was identified, maybe consultants would have been commissioned to deliver the training. That was their job. They got paid and they went on to the next job. There was little, if any, follow-up. Now, because partnerships are based on relationship, what we find is that even when the funded intervention comes to an end, the relationship continues. And there is opportunity for ongoing and sustainable support to the overseas institution. So in THET, we have to constantly remind ourselves that there is a difference between the project, that's the time-bound thing that we fund and put money into, and the partnership itself, which provides the basic infrastructure and relationship to deliver that project. Some of the partnerships we work with have been going for 20 or more years. They raised funds themselves to do what they're doing, and we only came along with some funding around about 5 years ago. Now, in international development and global health circles, much of what we do and how we do it in a contemporary setting comes from the principles set out in the Paris Declaration on Aid Effectiveness in 2005. And this is what essentially was decided at that summit. In 2005, we moved from that participatory development pattern to a pattern which said that ownership should rest with the partner countries, donors should align with partner countries' agendas and systems, donors should harmonise their efforts with other donors to prevent aid fragmentation, and there was an emphasis on managing aid for results and mutual accountability. So the Paris Declaration was important because it placed an emphasis on development interventions being led by the South in an attempt to stop developed countries doing development to developing countries. There was a new emphasis on partnership, a step further on from these ideas around participatory development which emerged in the 70s and 80s. Partnership became the thing to do. But what we've seen since then is arguably not quite what was intended. A couple of writers, Cassie Impney and John Overton, in a journal in 2014, said this: "Such has been the popularity of this approach to partnerships in development that donors began to use the term widely in their mission statements and project proposals, often as a surrogate for participation. And they even adopted the term for themselves, donors becoming development partners, in a semantic sidestep that obscured the underlying and continuing imbalance of power." So what have we learned? Firstly, partnerships are a powerful and formidable force for bringing about change, but not just the immediate change, sustainable change. A great partnership never gives up or throws in the towel. Secondly, there are certain hallmarks of an effective partnership, which, if missing, are likely to render it ineffective. We've been working over the past 2 years or so to draw some of our learning about partnerships together in what we're calling our Principles of Partnership workstream. I won't go through all this here, but if you're interested in following this through, there are 8 domains there, so they're the headlines. And then if you go to our website, this is actually very much an interactive tool. So go to the website, and as you click on the second one, for instance, harmonised and aligned, if you go to read more, it then drops into a number of hallmarks which demonstrate what a good partnership does in that particular domain. Furthermore, it leads you into resources that can help you to follow that through and to read more and understand more. Some tools, indeed, around things like doing a needs assessment and so on. So we hope that it's a particularly helpful tool. So thirdly, it's vital that expectations are managed appropriately. Either side is capable of letting the other side down, but well-managed expectations and clear agreement at the outset will mitigate against this happening. For me, for us, it all comes down to trust. Let's think about that for a moment. If I'm going to enter into a meaningful partnership with you, or with a corporate body, or another NGO, or a government agency, I have to get to a position where at the very least I believe and know that you're not going to stitch me up. But more than that, I need to know and believe that not only do you want good things to flow from this relationship, you actually want the best. And of course, for this to work, you need to know and believe the same about me too. So now we begin to see why we can't approach partnership in a formulaic way. I think what's interesting about this partnership model is that it can quickly adapt to changing needs and demands. The Sustainable Development Goals throw down a challenge to the world to achieve universal health coverage for all. In the context of low and middle-income countries, achieving UHC without a competent health workforce will forever remain an aspiration and no more. Of course, there's more to UHC than just the workforce, but we see from our experience and the emerging evidence of effectiveness that institutional partnerships, often with modest amounts of funding, are able to deliver transformative change. I realise that's a bold statement, so let me explain a little more. Firstly, health partnerships are transformative because they promote equity. They shift the focus from the old paternalistic model of development to a world turned upside down, where patient-centred solutions to problems are mutually developed and knowledge flows both ways. I should, at this point, the cartoons you're going to see in a moment are a part of the process that we've been through with DFID in our formal evaluation of our programme. And the evaluators employed an illustrator to be present at 2 of our workshops. And as we were talking, the illustrator, on huge pieces of, I was going to say flip chart paper, probably not, I think it was probably slightly better quality, just stood there and started drawing what we were talking about. And so I couldn't resist the opportunity to include someone in this presentation. So secondly, health partnerships are transformative because the health workers who are trained are not trained in isolation. We're able to measure behaviour change over a long period, and we see that there is a cascading of knowledge and skills which takes place on a formal and an informal basis. Even when the funding for a specific project has ended, we see the sustainable effect of that training because often there has been lasting systemic change. Thirdly, health partnerships are transformative because they're mutually beneficial. In the UK, the NHS recognises the learning opportunities of allowing UK health workers to engage in global health. There is growing evidence to suggest that the potential for the NHS to gain from these global health activities is significant, not just in terms of personal development, but also in converting that personal development into behaviours which ultimately benefit patients in UK hospitals. For the past 5 years, we have, if you like, been conducting something of a laboratory experiment through the Health Partnership Scheme. We've looked at what has worked, and worked well and done more of it, and we've looked at what went less well and modified our approach in the light of that learning. This month, I'm pleased to say that the long-awaited DFID evaluation of the Health Partnership Scheme reports that the evaluation findings overwhelmingly demonstrated the effectiveness of the partnership and volunteering approach in supporting health worker capacity strengthening. It's good to know you've done something right. So that's all well and good, but what can I say about successes and failures? In the end, success is in understanding and applying the principles of partnership. Failure lies in ignoring them. I'm sorry to be so simplistic. I almost feel embarrassed that you've invited me here to address you, and I turn up with such a simple message. I could have done it in an email. So what next? So we know that the UK government will, subject to final ministerial approval, give the go-ahead to a successor programme of roughly the same size next year. Whether THET will be the managing agent for that programme will depend on our successful bidding for the contract. But what we do know is that the UK government recognises the value these transformative partnerships bring in addressing the health workforce challenges in low and middle income countries, and also in strengthening the provision of health services at home. So I'm delighted to have had this opportunity to speak to you today, and I have the greatest admiration for the work of Esther Ireland in developing partnerships which can make a real difference. And I know the stories that are in this room, some of them at any rate, and looking forward to hearing more of them. I can assure you that we at THET will play our part in supporting you to do even more in the coming years. Thank you.